So some people have come along, so we might make a start now. Thanks everyone for coming tonight. I'd just like to begin by acknowledging the traditional owners of the land on which we meet today. And I'd like to pay my respects as well to elders past and present. So thanks everyone for coming tonight. Before we start, I want to introduce a couple of things. We'll be doing questions at the end of the seminar, and we'll be using Slido as our question software today. So that'll be a website that Rachel is going to link in the chat. And if you have any questions, please put it through Slido, or you can also use the link on the slide in front of us. As well as that, we also have a plushie to hand out at the tonight. So that'll be a giant blood cell plushie, which is very exciting. So for those who have attended and are UniMelb students and members of our society, you can look forward to being in the running for one of those plushies. Okay, so on behalf of everyone, on behalf of the Australian Student Society of Haematology, I'm very happy to introduce Dr. Stephen Vaughan. Dr. Stephen Vaughan is a clinical haematologist and a medical oncologist with a practice at Epworth Freemasons in Melbourne. He is also the director of Epworth Healthcare's Cancer Service Clinical Institute, which specialises in the diagnosis and care of cancer patients and provides a full range of treatment options on site. So he's got both experience in haematology and oncology, so very well equipped to deliver the seminar tonight. Thanks, Stephen.
Thanks, Gabriel. I'm just going to go through about 30 odd slides illustrating things. Because it's about leukemias in general, you could have a whole lecture on just one part of a particular leukemia. So what I've tried to do in this lecture is emphasize features that are common to all the leukemias rather than just focusing on one leukemia, although I will talk a little about particular leukemias in some aspects. I mean, I know you want to have the questions at the end, but I would probably prefer to be interrupted if you want amplification of some issue or you want me to spend more time on one issue. So Gabriel, if you could just, or anybody else, just call out and I'll amplify, because in a topic like, in a very large topic like this, in 1 hour, obviously there's going to be a lot of selection. So I really want to talk about the things that you want to talk about. Okay, so next slide.
Yep. 1 second. Oops. There we go.
So the sorts of things I want to talk about are origins, classification, a little bit about epidemiology and risk factors, diagnostic methods, management, and what I call emergent issues. And then there's a couple of references at the end, but I can supply further references for particular issues that you're interested in. Next slide. So origins, next slide. Sorry, that back one. So the standard way of thinking about all hematological malignancies is to think of a multipotent hemopoietic stem cell on the left of the diagram. And then that divides into myeloid progenitors and lymphoid progenitors. The lymphoid progenitors divide into T, B, and NK cells, and the myeloid progenitors divide into the 6 cells of that lineage: red cells, mast cells, platelets, neutrophils, monocytes, and osteoclites. So the traditional understanding of leukemia was to follow that sort of classification of origin. So you'd had T cell, BLL, B cell, cancer, NK cell, and then you had leukemias that looked a bit like neutrophils or monocytes or whatever. So the reality is that that similarity of the leukemic cell to the cell which it corresponded to hasn't really been all that useful, and we now think about the classification in a much more different way than we did previously. But that's the way leukemias are divided up, on a sort of cell of origin basis. Next slide. Whoops. We've lost everything. Hello?
I'm sorry, it's a bit, it keeps going on and off. And I can recommence the screen share shortly. Sorry about this. Okay. it working again?
Yeah, so this is another way of thinking about the classification. There are stem cells and then at early points of differentiation. Just an observation at this stage, it's likely that leukemias originate in stem cells. And in some conditions like myeloproliferative diseases like polycythemia rubra vera or essential thrombocythemia, the genetic abnormality affects all cell lines and therefore it's going to be a stem cell abnormality. Next slide. The classification and importance, sometimes people get exercised about what you call leukemia and what you call lymphoma. And when I was much younger, that used to be something that worried people, but now the whole focus is really on the cell type and we don't really make much distinction whether it's in the blood, leukemia, or whether it's in the lymph nodes, lymphoma. It's the cell type that matters because that's what determines the treatment. It makes up 8% of all cancers. The diagnosis is much more complicated than, say, traditional cancer diagnosis. Treatment is intensive and very costly. And the complicating factor from my point of view, I treated acute myeloid leukemia essentially the same way when I started specialist practice in 1981 up until about 2017. It did not change one bit. It was just a particular induction treatment that everybody used. In the last 3 to 5 years, there's probably 5 brand new drugs that you use in acute myeloid leukemia, for example, and the whole approach to the disease has changed. So nothing at all really happened in AML apart in terms of initial drugs for 35 years. And then suddenly there's been and that change is based on a much better biological understanding of the condition. And hematological malignancies have always been curable in a significant proportion of patients. The irony is that if you look at childhood ALL, how long ago? 50 years ago, the cure rate was about 10 or 15%. Now it's about 80%, but the cure rate improved from 10% to 70% with no understanding of the disease, just empirical trial of different drugs. So although you'll hear a lot today about understanding the biology of the disease is really important, and it is, a lot of the advances in the treatment of leukemia were just done trying drug A, drug B, drug C till you see what got the best result. And it's important to remember that, and particularly with childhood ALL, 80% of the improvement over the last 50 years has been purely empirical. And the understanding the molecular biology and the cytogenetics of it has improved things, but only 5 to 10%. The people who do molecular biology, and I'll come to this a bit later on, think that it's all due to molecular biology, but in fact, most of the initial advances were purely empirical. Next slide. So you think of disease in terms of the cell of origin, myeloid and lymphoid. You think of chronicity, acute or chronic. Acute leukemias come on suddenly. People are unwell for a few days to a few weeks. And if you don't intervene, they can die quickly in that time period. Chronic leukemias come on over months or years, and the symptoms are not as acute. So there's 4 basic types of leukemia: acute myeloid, chronic myeloid, acute lymphatic, and chronic lymphatic. Then there's a couple of leukemias that sit outside that classification. The one I've listed there is called hairy cell leukemia. And that's because when you look down the microscope, the cells have filamentous projections. We won't talk further about that today. And there's a couple of other leukemias, rare things called chronic myelomonocytic leukemia. But for the purposes of this lecture, we'll be focusing on the 4 basics divided by cell of origin versus chronicity, acute or chronic. And that gives you 4 types of leukemia. Within the, say, AML, however, that's further divided into 7 or 8 subtypes. And ALL is divided into T, B, and null, and also NK cells. All CLLs are B cell diseases, and we won't talk about hairy cell. Next slide. Just to give it a sense, if you're a haematologist and doing malignant disease, what do you spend most of your time treating? You spend a lot of time treating CLL and Hodgkin's disease and non-Hodgkin's disease and myeloma. You don't see much ALL, and you don't see much, well, that's because that's rarer in adults, commoner in children. So that's the sort of proportion of in the population of the various diseases and how you spend your time. So easily the commonest disease you're treating as a haematologist is non-Hodgkin's lymphoma. That's a very heterogeneous group of diseases and includes about 20 subtypes, but we won't further talk about that today. Next slide. Symptoms of leukemia, they're what you might call as protein because they're usually due to either anemia, thrombocytopenia or neutropenia. Neutropenia, a patient presents with sepsis, thrombocytopenia with bleeding, and anemia usually dealing with systemic symptoms like fatigue, fever, and shortness of breath. But basically, occasionally patients with leukemia present with bone pain due to bone marrow infiltration. Occasionally they present with skin nodules due to leukemia. Sometimes it's picked up incidentally, particularly with the chronic leukemias, when you examine their abdomen and you find out they've got an enlarged spleen or liver or lymph nodes. So they're the presentations of leukemia. They're not particularly, they don't have much probative value because they've often got lots of other causes and the diagnosis is not established on those. That's just the sort of things people have. Next slide. So the blood picture is one of anemia, thrombocytopenia, and white blood cells can either be grossly elevated in, say, an acute leukemia, but there is an entity where you can have leukemia in the bone marrow and not in the blood. And in fact, the white cell count is low. But mostly with leukemias, the white cell count in the blood is high. And often on peripheral blood examination, just a normal blood film, you can make a reasonable guess as to whether it's a myeloid leukemia or a lymphoid leukemia. And chronic lymphatic leukemia, chronic myeloid leukemia, acute lymphatic leukemia, and acute myeloid leukemia, probably just on full blood examination by an experienced hematologist, you can be about 85 to 90% accurate in saying which one it is. And we'll have a look at those pictures in a moment. Now, initially we used to make, when distinction was difficult, we used to do cytochemical stains. They're not done anymore. What we do these days is flow cytometry with cluster designation or CD markers. And then we do lots of special tests, in particular cytogenetics and molecular studies. But the traditional classification, to put them into those four basically groups, in 85% of cases can be established just by simple examination of the blood film. As part of my training, I worked for a couple of years in pediatrics and I do a bone marrow on some 4 or 5 year old child. I get up to the lab, I put the slides in the stainer, and just as I reached out and put it under the microscope, the treating clinician was standing behind me and saying, is it acute lymphatic leukemia or acute myeloid leukemia? Because the treatments were quite different. These days, that workup takes several days, but in those days, we used to make a call on the morphology, which is reasonably accurate, but not totally accurate, and certainly not sufficient these days. I'll talk about those issues a little bit later in the talk. Next slide. So that's morphology, looking down the microscope, and it's the resemblance to normal cells. There's immunotyping based on surface marker studies. I've just put one of the surface markers there, CD20, but there's CD5, 7, there's a whole range of them. And based on the pattern of surface marker studies, you could get a pretty good idea of what sort of leukemia it is. The cytogenetics of the traditional type, which we'll talk about lately, but more recently, the classification's almost always been molecular, because morphology, immunotyping, and cytogenetics still don't adequately classify leukemias, and you have to have molecular studies these days. And molecular studies are for two purposes. Or three purposes. They're predictive of the type of leukemia. They're prognostic in their presence or absence makes a difference to the prognosis. And more importantly, they're sometimes predictive of response to a particular treatment. So when you look at biomarkers, that's the broad word for these things, you're thinking about it being predictive of treatment response or prognostic, or predictive of a disease category. Next slide. So bone marrow examinations, if you're a haematologist, this is the only procedure that you do, so you've got to be good at it. Have any of you done a bone marrow? They hurt quite a lot. It used to be said when I was a registrar that you had to have a bone marrow so you knew what it was like. I never thought that was such a good idea. I could see that they hurt. The problem is, as you stick that needle in, you can give anesthetic to the skin, and that gets rid of that problem. And going through the cortical bone doesn't hurt much. The problem is it makes a crunchy sound, and patients don't like that much. The pain that you can't deal with any local anesthetic is what's called aspiration pain. When you suck marrow out, that hurts like hell. And these days, mostly we give a pre-medication. In children, I used to use hypnosis, but that's a procedure that if you're going to be a haematologist, you've got to learn how to do. Next, morphology. Now, which of you has got an aesthetic sense? Do they teach you anything about that? I can only see 2 pictures on my screen. Are there more of you than that?
Like 50 people here.
No, have any of you got any artistic qualities? No?
I'm sure someone in the crowd does.
I've always found looking at cells down microscope as satisfies my fairly limited aesthetic sense and identifying confidently different cell types. So this is a normal bone marrow. You can see the dark blob is a normoblast or red cell precursor. The big cell in the center is a metamyelocyte. It's got granules, and then there's various stages of neutrophil maturation, promyelocytes, myelocytes, and there's something getting towards a mature neutrophil, and then the bottom right looks like a lymphocyte, and then there's the red cells in the background. It takes you about 20 years to become very good at morphology, and it's really a very much, and you need massive experience. The trouble is that morphology now has been largely gazumped by the other techniques. But I'll tell you a little story. The patient, when I was a haematology registrar, was developing a monoclonal antibody to identify monocytes. So she gave me a slide like this with all these destroyed cells and what were they? And I said, look, they're monocytes. And she said, oh, I'll call it a monocyte antibody. There seemed to me to be a certain circularity about that type of reasoning. But that's the way it works. Next slide.
I have to just unshare it. Oh, there we go. Never mind.
So this is acute lymphoblastic leukemia, high nuclear cytoplasmic ratio, homogeneous set of cells. You can see some of them have got cleaved nuclei, like they look like a natal cleft. And we used to think that was indicative of T cell origin, but it probably isn't. So you could confidently say that's ALL. Next slide. This is acute myeloid leukemia. There's some granularity of the cytoplasm, the nuclear cytoplasmic ratio, and there's a thing called our rods, which are little short red stick-shaped things that you sometimes see in the cytoplasm, and if they're present, you can be confident that it's acute myeloid leukemia. Cells are probably bigger than acute lymphatic leukemia. Next slide. This is chronic myeloid leukemia, and the thing there is there's a range of red cell precursors. White cell precursors ranging from immature white cells through what's called band cells to mature lymphocytes. And you'll see there's a basophil towards the bottom with dark black granules. They're basophils, and that's again a feature of chronic myeloid leukemia. So if you saw that film, and the white cell count might be 100 or 200,000, it looks like it'll be at least 200,000. When you look at the background red cells, it's a very high white cell count. You can be quite confident looking at that film, that's chronic myeloid leukemia. Next slide. Age incidence. This is acute lymphatic leukemia, and the thing to note is it's on the vertical axis is incidence per 100,000, on the bottom axis is age. There's a very pronounced age peak in ALL in early childhood. Age has a significant prognostic factor. If you're older than about 6 when you get ALL, the prognosis gets progressively worse. So if you're 10 with ALL, that's old. The reasons for that are not clear, but acute lymphatic leukemia has that very characteristic temporal profile by age. Next slide.
Stephen, we do have a question from one of the attendees. There are many overlaps in symptoms between leukemia and lymphoma.
Yeah.
What is the main difference? And
Well,
probably, yeah. And is it that there are blast cells in the serum in leukemia?
well, the significance of circulating cells in the blood is that they displace normal cells so that you're thrombocytopenic, neutropenic, or anemic. I don't think symptomatically there's much the traditional definition is leukemias in the blood and lymphomas in the lymph nodes, but that distinction breaks down, and I don't think the symptomatic presentations are much different. I mean, lymphoma patients can often present with constitutional symptoms like night sweats. They can present with fever, all those things. I don't think it's useful to talk much about the symptomatic differences.
Yeah. There's another question that's come in as well. Is the blood test essentially normal in lymphoma? And possibly from the same person, this question.
It depends on the technique. To visual examination, your ability to pick up an abnormal cell population based on microscopic examination is probably about 1 in 100. So in most lymphomas, you don't see any circulating lymphoma cells, but if you do the much more sophisticated tests, flow cytometry, or say next generation sequencing, even in lymphomas, in most of them, you pick up a population. As you do in non-hematological malignancies, these days, the sensitivity of tests on blood is in probably most breast and bowel cancers, we pick up circulating tumour cells. So that's a question about the sensitivity of the technique. And most cancers probably have circulating cells, including leukemias. But on conventional light microscopy, they're at such low levels that we don't see them.
Thank you.
Next. This is acute myeloid leukemia. It's essentially a disease of old people. There's no significant peak in young childhood. And the significance of it is it exists in people mostly, say, more than 2/3 of them over 70, 74. And these people have lots of comorbidities. They have heart disease, diabetes, airways disease, and the treatment of acute myeloid leukemia is often complicated by comorbid diseases. These days, we talk about comorbid diseases, but the most significant issue is not chronological age, but what we call frailty. And the best index of frailty is their functional status, what can they do, and their muscle mass. So if you do a CT on these people, their psoas muscle mass, which is a mass, is often quite reduced. So that one of the biggest prognostic factors in all types of cancer, including the hematologic ones, these days we think about frailty rather than age per se, because you can have a 70-year-old who's very frail, and you can have a 70-year-old who's very fit. And that's what determines their outcome, not their chronological age. Next slide. Chronic lymphatic leukemia is again a disease of older people. About half the people present with chronic lymphatic leukemia, unlike acute myeloid leukemia, present asymptomatically. They have a blood test for some other reason, because this is a very indolent disease. And probably a third of the patient you see initially, you don't even treat because they don't require treatment, and they can often go on for 5, 10 or 15 years without any treatment. The thing to remember about chronic lymphatic leukemia, even though they may not require treatment, they are still quite severely immunosuppressed related to the genesis of their leukemia. And you have to be very careful when they get infections, even when they're at an early stage of their disease. The treatment of chronic lymphatic leukemia, when it's required, has changed dramatically just in the last 5 years with a whole lot of new drugs. Next. Chronic myeloid leukemia, just to go back to the previous slide, sorry. Just notice that on the vertical axis, the numbers are changing. So when you go to there, the incidence rate's from 0 to 35. So that's a common disease per 100,000 per year. Go to the next slide. See, there's a different scale there. CML is a much less common disease. And there's a bigger incidence in middle and late middle age. It's not quite got that geriatric curve. There's more people you see in their 40s and 50s with chronic myeloid leukemia. If you want to think about leukemia, chronic myeloid leukemia is, or for cancer in general, is the model disease, and we'll come to that later.
I have another question from the audience.
Yep.
Why is CLL considered the equivalent of SLL?
Mm-hmm.
Why is CLL considered the equivalent of SLL is the question.
Because it's, if you look at the cells morphologically and you do surface marker analysis, they have the identical surface mark. It's the same cell. And the reason why in one patient it manifests as chronic lymphatic leukemia, mostly with blood, but in chronic lymphatic leukemia, they've often got lymph nodes, but we call it leukemia because it's in the blood. And the next patient you see has got nothing in the blood, but it's got lymph nodes. It's the same cell. It's treated the same. So it's just purely a clinical convention related to the type of presentation, but there is no difference in the treatment.
Thank you.
So that the corresponding lymphoma is small lymphocytic lymphoma is the same as CLL. Next. So this is a standard cytogenetic profile with chromosomes numbered 1 through 22 and the X chromosomes. This technique of karyotype analysis has been around for 50 or 60 years. It's a very insensitive technique, but nonetheless, with chronic myeloid leukemia, it was the technique that identified the translocation that's important in that disease. My best guess is we'll stop doing this in the next 3 to 5 years and we'll rely purely on molecular techniques. It's like morphology and standard cytogenetics. They've largely been superseded by more sophisticated techniques. So don't become a person who does cytogenetics, is my advice career-wise. And probably don't become a morphological haematologist. They're both careers that have a limited lifespan. Next slide. I'll get to some more career advice later. So this is really important, and this has been known for 30 or 40 years, chromosome 9 and chromosome 22. The ABL at the bottom of chromosome 9 breaks off and attaches itself to chromosome 22. The significance is that at those breakpoints, there's a gene called BCR and there's a gene called ABL. And when they're separated, they have no adverse effect. But when they come together because of the translocation, the BCR-ABL gene product is what causes CML. So two genes normally separated on separate chromosomes come together and they produce an abnormal gene product, which causes chronic myeloid leukemia. Next slide. Molecular studies. Now this is meant to intimidate you, this slide. This is ALL. And are you aware of the hallmarks of cancer?
Yep, I think we've
if you read around the outside of this disc, they're the sorts of hallmarks of cancer. And on the inside of the disc is the particular genes in childhood ALL, this is. And those particular, on the inside disc, it's divided into high risk, low risk, and intermediate risk. And each of those genes tells you which case the patient falls into. So these days, you get a child with ALL, you do the bone marrow, it's ALL, you wait for the molecular analysis, and then you classify the patient into high, intermediate, or low risk. And on that basis, you determine their treatment. Nobody these days would treat a leukemia without this sort of analysis. Now, the wheel looks different for AML and CML, and the other leukemias. This happens to be the one for ALL, and that's what you need to know before you start treating a child with ALL. On the outside, it just refers to the process that the particular gene affects. And at some stage, you should look up the hallmarks of cancer because it's related to that. Next slide. This is another way, this is for AML, and what this is the genes FLT3, nucleophosmin, and IDH2, IDH1, RUNX1. They're the genes that are active in AML. This is a series of cases, each case represented by a little vertical bar. So you know that in 28% of AMLs, FLT3 is mutated. NPN's mutated in 27, and the graph allows it to tell you those patients that might have all 3 or 4 mutations overlapping. So it's a way of representing genetic mutations in AML in this particular case. And the importance of that these days is there's special drugs directed at FLT3 and IDH and NPN. And so these factors both have prognostic significance, and they also have, of more importance, they have significance for drug treatment selection. So that's just the way in acute myeloid leukemia of representing the various genetic profiles. Next slide. Here's the importance. If you divide patients with AML on the bottom table up below into favourable, intermediate, and adverse risk, the survival curves, which are on the vertical axis, what's called relapse-free survival, and on the horizontal axis time, you can see the genetics divides patients into 3 very clear and distinct prognostic subgroups. So at 96 months of follow-up, which is 8 years, 50% of the favourable patients are in remission, and only about 5 to 10% of the adverse are in remission. So that's molecular studies being predictive of prognosis. They're also sometimes predictive of which treatment you should use. So you've got to think about biomarkers or prognostic factors in terms of predictive or prognostic. So that's why in AML, if you're talking to a patient and about undergoing intensive and life-threatening treatment, these days, a lot of people with adverse prognostic features, we wouldn't treat them at all. And given that most of these people are over 70, many of them have comorbidities, and they won't survive the treatment anyway. And with those sorts of results, if you present these to patients, most of them are not interested in treatment. So that's the importance of the molecular risk factors of prognostically stratifying patients so you can decide whether treatment's worthwhile, and also in some cases selecting a particular treatment. Next slide. So the management of acute leukemias, and just remember I'm making a distinction here between acute and chronic leukemias. This is acute, it's urgent. You need a prompt diagnosis. These patients often will die within a couple of weeks if you don't treat them aggressively. You need intensive supportive care, mostly with systemic therapy, but for some patients, there's additional targeted therapy. And for patients that are sufficiently fit and whose prognosis is otherwise poor, you might offer a bone marrow transplant. There's a thing called CAR T cells. Have you heard of those? We'll get onto those in a minute. There's various monoclonal and bispecific antibodies for leukemia. There are special issues with leukemia with the central nervous system. ALL in particular, but also AML has a propensity to involve the meninges. And most of the traditional chemotherapy drugs do not penetrate the blood-brain barrier. So you've either got to inject drugs into the spinal fluid by a lumbar puncture, give them a radiation, or you've got to give drugs like methotrexate at 100 times the normal dose and then rescue them to get the drugs into the CNS. So the treatment of the CNS is a big issue, particularly in children, because radiotherapy to a child with leukemia knocks about 20 points off their IQ, causes growth retardation. So there's been a very aggressive attempt over the last 20 years to try and minimise radiotherapy in children. And even now in adults, we tend to be apprehensive about radiotherapy because of its long-term consequences to the central nervous system and the spine. The whole concept, you go through a phase of treating a cancer where the treatment's no good and then it gradually improves, and then you start worrying when patients start surviving about late toxicity. And if you look now at children treated for leukemia between, say, 5 or 6 years old, when they're 20 or 30, they get accelerated cardiovascular disease. There's a whole range of issues, endocrine problems. So our initial focus was also on immediate and early toxicity. Now the focus is on late toxicity. I mean, just to digress from leukemia, if you look at Hodgkin's disease, where the cure rates are about 95%, but of the women who have radiotherapy to the upper mantle, about 20% of them get breast cancer 20 years later. So a lot of the focus these days, particularly on the leukemias and haematological malignancies with the high cure rate, is what is the long-term consequence? And you have to think about that. And the tendency is to try and give less radiotherapy, try to give less cardiotoxic drugs. If you have a drug called doxorubicin, it damages your heart. You can reduce that a bit by keeping the dose down, but 20 years later, you get accelerated ischemic heart disease. So we have to be mindful of all those. So particularly in children, but even now in adults, say in breast cancer, radiotherapy to the left breast gives a big heart dose. You add on top of that some doxorubicin, and you end up in a woman going to heart failure in her first pregnancy when she's 40 or something. So there are lots of issues about long-term toxicity, particularly when the results of treatment are good. And they have things now called survivorship clinics where you keep an eye on patients for 20 years to pick up these complications. Next slide.
There is a question about something a bit earlier in the presentation. Is it counterintuitive that leukemia is characterized by a high white cell count, yet patients can be neutropenic and thrombocytopenic?
Well, the white cell count measures the number of white cells, but although they might have a high count of leukemic cells, they often have no normal neutrophils. The leukemic cells have no immune function. So you might have a white cell count of 100,000 and no neutrophils or platelets. So that's the reason. The other thing is that you often think of cancer and leukemia as a disease of rapid growth, but chronic lymphatic leukemia, for instance, is not a disease of rapid growth. It's a disease of accumulation. Normal cells go through a process of being born, serving a function, and then dying. Chronic lymphatic leukemia is they won't die, so they accumulate. So you have this concept of cancer rapid growth. Often it's just accumulation. The cells won't die, so they accumulate.
And there's another question as well. How prevalent is the resistance to small cell molecule inhibitors like imatinib and CML, and how often do you change the drug?
Well, CMLs, we might just let me look at the slides.
Yep.
Just hold on. I'll just see. Well, I'll talk about it now. Chronic myeloid leukemia. Firstly, about 35 years ago, the Philadelphia chromosome, or the 922 translocation, was discovered. Then that created this abnormal gene product called BCR-ABL. Then they discovered a specific drug called imatinib, which antagonized that. And chronic myeloid leukemia in my practice lifetime has gone from a disease with an average survival of about 5 years to 7 years to a disease that now is mostly cured. The first generation imatinib mostly works, but there's 2 or 3 second and third line and fourth line cousins of imatinib, which you sometimes have to use because either they don't tolerate imatinib or imatinib doesn't work successfully. But with those drugs now, you're looking at cure rates. You're looking at CML now, not only curing the disease, but being able to stop the drugs once they go into complete remission. And I'll come to that a bit later. But the proportion of patients that respond to imatinib, and those that have resistance. That depends a bit on where you are in the patients. Next slide. I think let's just jump over that. Now, you're familiar with the concept of a multidisciplinary team meeting? On the left, and this is really for cancer, but if you could just replace oncologists with haematologists, for my sake, and you had X-ray people and you had the pathologists, the haematologist or the histopathologist. These days, in a multidisciplinary team meeting, you need a molecular diagnostician who tells you what all the molecular studies, because they're very complicated. There's all sorts of measurement and laboratory issues. You probably need a clinical bioinformatician. Do you know what that is? If you do an analysis of, say, a whole genome, 6 million base pairs, and with several identified driver and or passenger genes, the only way you get any sense out of that is by the application of a commercial and usually proprietary piece of software that analyzes it for you and punches out a result. You need the person who understands that process. And you need a curator who looks at all the genetic abnormalities and decides what they mean. And you need an immunologist probably. So, and when you're thinking about your careers in future, haematologists will not have, some of you will be a haematologist and a molecular diagnostician. Your career will have to have one of those streams in it. Being a straightforward haematologist will not be enough. And I'm talking not in 20 years, I'm talking in 5 years. So the amount of the number of experts you need around the table to get the right treatment decision for for any patient in haematology now is just like that. And that's got that, you need to think about that in your career choices. And I'll come back to that a bit later. Next slide. This is an important slide. There's a concept called MRD, which is called minimal residual disease. And the objective of treating leukemia is to get minimal residual disease. The measurement of that, however, is very technique dependent. If you look at those blue arrows, second from the right, there's MFC, which is a multi-parameter flow cytometry. Under that's PCR, polymerase chain reaction, and under that is next generation sequencing. As that arrow goes down, and you can see it goes from 10 to the 0 to 10 to the -6, that's the sensitivity of those tests in detecting minimal residual disease. Typically, we used to function in the blue zone at the top, where we did a bone marrow or a full blood examination, and we thought people were in remission once they dipped below the first dotted line. You know, 10 to the -1, 10 to the -2 cells. We now understand that most patients have residual disease that wasn't picked up with our initially insensitive tests, and as our tests for detecting minimal residual disease get better, it's apparent that we've got to be aiming for the red line. And we've now got techniques, particularly next generation sequencing, that can allow us to identify when we get a patient down to that level. Because you find basically if people have still got residual disease, either the top two blue lines, they relapse. So the concept of minimal residual disease is now relevant to all leukemias. So that's why I've put it up, because it's a concept that you need to understand. Any questions about that?
I was wondering, would you, if you don't know, or if there's a possibility that there will still be some residual disease, would you not just continue treatment past
Well, that's the issue. First of all, you have to establish, if you take those three curves, we'll take the middle curve. We know from experience that if they've still got disease on PCR, they'll relapse. So what you'd think to yourself, let's just, the people who have residual disease on PCR, will give them more treatment. And the people who don't have residual disease on PCR will stop treatment. That's the sort of decision you make. Because it's almost certain if they've got disease on PCR, they'll relapse.
Yeah.
And that's the way the concept works. there's a bit of religion about minimal residual disease. Do you know what I mean by that? I don't wish to be dismissive of religion, but it's belief that goes upon the available evidence. And people who are strong believers in minimal residual disease concept, and I think it's sort of mostly true, but it's not completely true, they end up belting the shit out of patients with overtreatment. And the question is, it really needs to be proven that the concept works, not the theory. And all those studies are in progress at the moment.
The question from the audience, probably a bit on this. Is that why patients are usually treated until their white cell count is basically 0?
That's the normal white cell count. Well, that's really operating in the top blue section. That's insufficient. What you're trying to do is, it's not the normal white cell count is not what you're treating. You're treating the leukemic cells. The normal white cell count decreases incidentally. What you're trying to do is to get down to the red curve. And that's why you give cycles of treatment. Say the first cycle of treatment drops the cells from down to sort of, 2 logs. The next cycle does another 2 logs, and the third cycle does another 2 logs, and then you're down to minimal residual disease. But a lot of that, we used to do that in the past, but we weren't able to measure it. Now we can measure it. And that's the key thing. Now we can measure how much we're getting the leukemia down.
Okay, and there's a question that may have already been answered, but so now the aim of treatment is to get to a point where there is no minimal residual disease, and how confident can we be based on what tests?
Well, the next genome sequencing, the NGS, is the best test we've got available.
Yeah.
But for that to work, the leukemia or the cancer's got to have a marker, and usually what you're looking for is the cytogenetic marker, say FLT3, and you're testing for that. In chronic myeloid leukemia, you directly measure the BCR-ABL by using next generation sequencing, and that system of monitoring the treatment of chronic myeloid leukemia by monitoring BCR-ABL, that's been a standard part of practice, initially with PCR, for the last 10 years. So you measure the BCR-ABL, you see the patient, you've got a target, and if you're not reaching the target, that's when you change to one of the second generation TKIs like ponatinib or dasatinib rather than imatinib.
Thank you.
If you think about leukemia, we've understood CML for much longer, and all the concepts that we have for treating leukemia in general have been developed in CML, and they're most advanced in CML. So if you read up the CML literature, it gives you a much better idea of how we think about leukemia, because the ideas developed in CML and practiced in CML are the ones that, and it's not just hematological malignancies, the ones we think about malignancy generally. So better measures for finding residual disease, changing treatment, increasing dose if you find residual disease till you don't find residual disease. That's the concept. Next slide. New treatments. The most important change over the last 10 years is treatment stratification by prognosis and subtype. So it's not really sufficient to say today a patient has AML. You need to say which type of AML, what are the surface marker characteristics, what are the molecular studies. And that applies to all the leukemias. These broad categorizations are insufficient to derive treatment. There's monoclonal antibodies for CLL and AML. There are bispecific antibodies. The initial monoclonal antibodies just attract one, you know about cluster designations, CDs, the antigens on the surface of cells. We now have ones that attack 2 of them. Small molecules like imatinib. Old drugs with new uses like thalidomide. It's paradoxical in some respects, the intensity of treatment has increased. It troubles me. For the last 35 years, I've been treating AML with very intensive treatment, hospital for 4 weeks, treatment-related mortality of 5% or higher. And there's now a drug called venetoclax that I can give as an outpatient as a tablet. Same results. So in some respects, the intensity is increased, but in other respects, it's decreased for the same outcome. CAR T cells we'll talk about in a moment. Bone marrow transplants, in particular graft versus host disease, there have been a number of major advantages in bone marrow transplants. They're now much less toxic. Graft versus host disease is either prevented or treated. And always, particularly in elderly patients with AML, with multiple comorbidities and failure, sometimes the best treatment is no treatment, no chemotherapy treatment. In the sense that we know the prognosis based on risk stratification is so bad with the treatment that you just don't give it, and that's sometimes the right treatment.
There's a couple of questions here.
Yeah, sure.
So how often do patients get infections during treatment when they are neutropenic?
Well, two things. You give colony stimulating factor to accelerate the recovery of their neutrophils, but I would guess that during the treatment of acute myeloid leukemia, probably 20 to 40% of people get an infection each cycle. And the problem is with infection, when you treat, say, acute myeloid leukemia with conventional chemotherapy, you wipe out their normal bone marrow and their leukemic cells, hopefully, for 3 to 4 weeks. If they get an infection on day 1, you're in trouble because you've got to keep them alive without neutrophils for 3 weeks. If they get an infection on day 21 and they're going to recover in a couple of days, it's less of a problem. If they start out with leukemia with an infection, then you're in further trouble. But mostly these days, infection's common, but it's not many people die of sepsis these days. The sepsis we have most trouble with is not bacterial, but fungal, and that often comes later in the course.
There's another question here as well, related. What percentage of patients survive the treatment?
The treatment-related mortality for acute myeloid leukemia is about 5%. That means they don't die of the disease, they die of your treatment. For the other chronic myeloid and the other leukemias, it's much, much less, but you really have to belt acute myeloid leukemia to get the disease burden down, and that's the accepted mortality. If the patient was 75 and had comorbidities, it might be higher. If they were 25 and otherwise well, it might be less. So there is a significant treatment-related morbidity and mortality with treating acute leukemia. Some of it's related to drugs, certain drugs you give. There's a drug called asparaginase, which you give for ALL. It can cause nasty thrombosis in the cerebral venous sinus, and I've seen several deaths. So there are some specific drug-related toxicities, but most of the toxicity in leukemia in the acute phase is due to sepsis, and mostly it's fungal or polymicrobial. They've got lots of bugs. All right, CAR T cells. You have a patient, top left, you take off their lymphocytes, T cells, you isolate them, activate them, you transfuse them with a viral vector, usually an adenovirus. Then you target them to a particular CD cluster. In ALL, you usually target CD19. You expand them and then you inject them back into the patient. Those T cells, now targeted at a moiety on the surface of the leukemic cell, attack the leukemic cell. This is called chimeric antigen receptor T cell treatment. This has been around for about 4 or 5 years. It's been in Australia for 2 years. The cost is $600,000. It's only approved in Australia for people, children and young adults with ALL, and some adults with refractory large cell lymphoma. It has 2 unique toxicities. One is called cytokine storm, where somehow this process activates all your cytokines, particularly interleukin-6, and you can die of that disease. And it also has a number of poorly understood neurological complications. But having said that, if you take a population of, say, kids with ALL who nothing else has worked, this is curing 50% of them at significant cost, financially and in terms of toxicity. It's been tried in ALL, it's now being tried in myeloma, and other hematological malignancies. It's been tried extensively in solid tumours, but because the T cells don't penetrate the tumour microenvironment, it's been largely unsuccessful so far. It was thought that it was going to transform all of cancer, but it's mostly only been successful in hematological malignancies, and that's probably due to the accessibility of the cells. Generally in cancer, it's not just the cancer cell, it's what's called the tumour microenvironment, which is a whole lot of cells that surround the tumour, including lymphocytes, macrophages, neutrophils, fibroblasts. And whether a tumour is successfully treated or not depends as much on the cancer cell as the microenvironment in which it exists. And there's a new group of drugs called immunotherapy that stimulate the immune response to cancer, and they deal with the tumour microenvironment. But for hematological malignancies, these CAR T cells, they are the future. And the present focus is to try them in a broader range of hematological malignancies and to try and reduce their toxicity, which can be fatal, maybe 10%. And the cost, $600,000. Expensive. Any questions about that?
None have come through.
Next slide. This is just, if you look at CAR T cells, they come in generations, first, second, third, and fourth. There's the plasma membrane, there's the antibody, the variable heavy and the variable light chains, and there's been various modifications to the intracellular, this part of the molecule here. They're either against CD3, CD28, when they have various moieties to improve their function. So it's a period, it's only been around for 5 or 6 years. It's being rapidly developed. And I suspect in 5 years, it'll be standard treatment for most hematological malignancies once we get the cost down and the toxicity under control.
There is a question about that, which is why do they cost so much?
Because at the moment, you plasmapheresis the patient in Australia, you've got to send the cells to New Jersey to be processed. It comes back to Australia and is injected into the patient. The patient might be in hospital for 4 to 6 weeks. I should tell you, by way of comparison, treating an AML costs about $200,000. 4 to 6 weeks of hospitalisation, high nursing loads, lots of expensive antibiotics, all of it. When I say it's 600,000, treating leukemia is about 200,000. And that's part of the cost. And it's a commercial product made by a private drug company. And there's only 2 companies that have got a product that's widely used. Once it becomes more widely used, there'll be more competition and the price will come down, I suspect. And once we get the toxicity under better control.
Okay, and there is another question about CAR T cells. Can you use someone else's T cells, considering the
At the
patient's?
moment, the original CAR Ts was your own. Now they're trying to develop an off-the-shelf CAR T where they take anybody's lymphocytes and they create a product that can be used for anybody. That's the next development, yes. I mean, this is a very rapidly changing area of medicine. We'll talk about this later, but I've got lots of references on these things if you want some fairly straightforward. If you could maybe, Gabriel, send me, if you could collate what references the reference I'd recommend to you particular is the one on CML, because it's the model disease. It allows you to think about all the leukemias. And then if you want stuff on CAR-C, if you send me an email with your requests, I'll send you the references.
Thanks.
Next slide. These are just antibodies directed at various cluster designations, CD20, CD19, CD22, the name of the drug, and in what diseases they're used. Monoclonal antibodies. Next slide. This is a bispecific antibody called blinatumomab. And what it does is it's an antibody that attacks 2 different cluster designations, on the right CD3 and on the left CD19. Very useful in the treatment of refractory Hodgkin's disease. Next slide. All right, conclusions. I'm not all that distressed that I'm retiring, you know, it's getting too complicated. In my early career as a specialist, I probably spent 10 hours a week doing technical reading. In my mid-career, I got it down to about 2 or 3 hours. I'm now back to 15 hours, 10 to 15 hours a week of technical reading just to keep up, because things are happening so quickly. The number of factors you have to consider in treating an individual patient have exceeded human cognitive limitations. Humans can usually only process about 4 or 5 bits of information at once. We're talking a leukemic patient now, looking at 100 factors maybe in a particular patient. And this leads on to machine learning and artificial intelligence. Again, I'm pleased that I won't have to deal with this, but you will. Have any of you got a background in mathematics or computer science? If not, acquire one fairly quickly. Because what you need to do as a haematologist, you need to understand what the geeks are doing. Because eventually you're going to apply it to a person who sits in front of you. And a lot of it's going to be black box. And you need to understand something about what's going on in the black box. Your careers will be, by the time you get to your training, you'll have to know quite a lot about machine learning and AI. And if you like, Gabriel, if you just include that in the list, I'll send you some references. We have a lot of new and improved treatments, but they come at incredibly high costs. And the question is whether we're going to be able to afford them. We have new toxicities, CAR T cells and various other drugs. And when you're using I've only really understood the long-term side effects of drugs I've been using for about 20 years. I've been involved with CAR T cells for 5 years. Who knows what the long-term side effects will be? We only picked up the damage that radiotherapy was doing to the hearts of women with breast cancer after 20 years. So you'd have to worry, even though the short-term results are good, what are the long-term toxicities? Haematology, in molecular terms, and the sophistication of diagnostic techniques is the most advanced specialty. And in places where I work, when we're trying to get molecular stuff rolled out to other specialties, we use the haematologist as an example, because the hematological disease are much better understood in a molecular sense than, say, breast cancer or bowel cancer, although they've made a lot of progress. So one of the things about being a haematologist, in terms of how diseases are going to be managed over the next 15 or 20 years, you're at the front of the pack in terms of specialties in having to understand these things. You need to make a bit of a decision about whether you're going to be a clinical or laboratory doctor. The way haematologists have been trained in the past, you do both. I no longer think that's feasible. The laboratory side of it has got increasingly complex, particularly when a lot of it's black box stuff and you're going to do a lot of machine learning. You're going to need people who understand all that. And the clinical stuff's always been complicated, and I'm not sure that you can do both well, or at least stay up to date. The personal reflection is that I started out and chose to be a haematologist because of sickle cell disease. Do you all know about that? Now, there's only about, well, when I was training, I did a survey of the 25 people in Victoria who had sickle cell disease. With immigration, particularly from Somalia, the numbers are now much higher. But I had this naive notion that once you understood the molecular defect in a disease, in sickle cell disease, the substitution of the 6th codon of the beta chain, the rest would all be pretty straightforward. You'd find its treatment. Here's the paradox. Despite that mutation being understood in sickle cell disease for 45 years, no specific therapeutics has been developed for that till last year. What's the answer? Why?
Probably emerging technologies in terms of actually in terms of
No,
interpreting.
people with sickle disease are black and poor and live in the third world. That's the reason. And so the reason I raise that with you is for you to understand that technology in the world's very uneven. And understanding the molecular biology doesn't necessarily translate. Most money spent on breast cancer and first world diseases. The second thing is, as a young specialist, I thought if you understood the molecular stuff, it all sort of fell into place. But the reality is clinical practice, at least, is understanding people. And there ain't much molecular biology in that. It's basically an interpersonal challenge. It's not a scientific challenge, looking after patients. So in thinking about your career choices, and I'll stop the preaching in a moment, you need to think about what do you want to do in terms of for the rest of your professional life. I think haematology is a great specialty because you can go either way. You can be a person who looks after patients and they're very demanding patients, they're acutely sick, or you can be a person who focuses on the understanding of disease, and there's lots of work to be done there. And not only that, but haematology will be a model for all other diseases. The end.
Thanks, Stephen. It was a really interesting presentation, and it was really interesting seeing like the new therapies that are emerging. I think, yeah, I haven't heard much about new therapies, but it's really interesting seeing what's coming up for hematology. There is a couple of questions coming up if you have time for them.
Yeah, sure.
So one of them is, how is a patient with leukemia still able to have normal neutrophils, albeit a low count? Are these residual, or is there capacity to generate normal cells still?
You never lose completely your capacity to generate, and people have low normal cells because if you think of those diagrams I showed very initially about the stem cells, you get diversion along the leukemic line, or you get crowding out. So there's just no space for normal cells because the leukemic cells have a proliferative advantage, and they just crowd out all the normal producing cells in the bone marrow.
Okay.
An interesting way to think about cancer is cancer cells have an evolutionary advantage and they crowd out normal cells.
And there's another question as well. What are some ways to differentiate leukemia with myeloproliferative disease?
Leukemias are characterised by high white cell count. Myeloproliferative diseases have often elevated platelet counts, elevated hemoglobin, and maybe elevated white cell counts. So a myeloproliferative disease is what you call a panmyelosis. You don't get elevated platelet counts or elevated hemoglobin in leukemias. And the manifestations of myeloproliferative disease are what's called a panmyelosis. Everything's increased. Leukemia, it's just the white cells.
Thank you. And there's a question, I think, from Yuda.
Hi, Stephen. Thank you so much for your wonderful presentation. I was just wondering, in terms of the immunosuppression, you were mentioning that some people with, I think it was CML, that was, you don't need to treat them. Oh, sorry.
CLL.
CLL, you don't treat them because they don't have any symptoms, but they are immunosuppressed.
Yes.
If they were to go into, I guess, their yearly flu vaccine, would they actually produce a immune response to that?
Yeah.
And you know, would they be able to use live vaccines, as some people, you know, get live vaccines just when they're adults? So yeah.
Well, I mean, firstly, the major cause of death and morbidity in chronic lymphatic leukemia is sepsis. Most of them don't die of bulk chronic lymphatic leukemia, although some do. You vaccinate them, but the vaccination response to killed vaccines is attenuated. They don't respond to vaccines. So the major thing you do is you've got to get them to present early with infection before it gets out of hand. And typically they get chest infections, urine infections, skin infections. So there's a very important educational component because a lot of those infections, like staph, there's no vaccination. So you've got to get them to present early. You give them pneumococcal vaccine, you give them meningococcus and Haemophilus, but they only provide partial protection. You give them the Zoster-Dead vaccine, but not the live vaccine. You don't give live vaccines because there's a risk of dissemination. So most of the management of early CLL is the early identification and treatment of infection by early presentation is the most important, and then vaccination, understanding that doesn't always protect them.
Okay, so I think we've reached the end of the questions. Once again, Stephen, thanks for coming to this
Sure.
seminar. It's been an amazing seminar, and I'm sure everyone here has gained from it. We have our exams coming up, so it's great to learn from more. And it's just, I think, interesting as well, learning about leukemia.
Always there's a question in exams about chronic myeloid leukemia and the Philadelphia chromosome, so you need to know that. And so if you could just send me a list of references, if you could collate what people want, and I'll send them to you.
Awesome.
And
Sure thing.
just to remind you again, that chronic myeloid leukemia is the moral disease. And if you understand that, all the rest of it falls into place.
Awesome. And thanks everyone for coming as well to the seminar. We'll be announcing the winner of our plushie afterwards on Facebook when we look through who's attended and we randomize the winner. But thanks everyone for coming as well. We might leave it there and see you
Is
around.
that another question from Warren?
I think this is doing a clap.
Oh, that's a clap, is it?
Yeah.
Thank you, Warren. Okay, thank you.
Thanks everyone.